Good evening, everyone. My name's David, and welcome to another one of ACPP's webinar series, which is the continuation of a regular set of professional development opportunities that we are running for paramedics. Before we begin, I'd like to acknowledge the traditional custodians of the lands where my Australian-based colleagues are located today and pay my respects to their elders past, present, and emerging, for they hold the memories, traditions, culture, and hopes of Aboriginal and Torres Strait Islander people of Australia. In recognition that ACPP is a binational college, I take this opportunity to acknowledge the Maori as Tangata Whanaua and the Treaty of Waitangi partners in Aotearoa, New Zealand. This evening, I have the pleasure of introducing my long-term friend, Dr. Lauren Shearer, who is one of Queensland Children's Hospital's consultant paediatric cardiologists. Dr. Lauren has over a decade working in a variety of paediatric and adult congenital cardiology roles across Australia and the UK, and she is passionate about integrating frontline paediatric cardiology knowledge across all healthcare professionals. Dr. Lauren has a particular interest for early cardiac illness investigation and diagnosis, paediatric palliative care, and child to adult transitional care. Dr. Lauren will be joining us again over the next few months to discuss her other interests relating to paediatric care. However, today she'll be focusing on key paediatric cardiology pearls and basic cardiac ultrasound interpretation for frontline and primary healthcare clinicians, including paramedics. For everyone who's joining us live, at the end of the presentation, there will be a short Q&A. If you have any questions, please feel free to write them into the comments section and I'll go through them in the order that they appear at the end of her presentation. Without any further delay, I'd like to pass on the webinar to Dr. Lauren. Thanks, Doctor.
Thank you very much, David. It's a pleasure to be here. I also want to acknowledge the Turrbal and Jagera people specifically. They are the traditional custodians of the land on which I'm presenting from today. The land and rivers of Meanjin and Brisbane have been a meeting place for thousands of years, and I'm privileged to present from here today. I also wish to acknowledge the traditional custodians of the lands on which each of you are living, learning, and working from today. As we share teaching and knowledge today, may we pay respect to their elders past, present, and emerging, and I want to particularly welcome any Aboriginal or Torres Strait Islanders joining us today. Now, I want to just briefly say I don't have any financial conflicts of interest to declare. Some of this talk was prepared as part of my work as Queensland Health, but it's presented in an individual capacity and it's not policy or otherwise representative of Queensland Health, and all patient images are presented de-identified and with specific permission for educational use. So a bit about me. I am a doctor. I trained originally in Melbourne, doing work through Melbourne initially before starting my paediatric cardiology journey. I did some extra fellowships, including in paediatric pulmonary hypertension at the Great Ormond Street in London, as well as fellowships in adult congenital heart disease at the Prince Charles Hospital and a clinical diploma in paediatric palliative care medicine. I'm currently a consultant at the Queensland Children's Hospital in Brisbane. Now, as with all experts in subject matter, please forgive me if I delve a little bit too far into the bushes. Sometimes it's easy to lose sight when you are so deep in a topic, exactly what other people will be aware of. So please feel free to ask any questions at the end of the presentation. And thanks to XKCD for this lovely slide. Now, paediatric cardiology is about the diagnosis, treatment and care of fetuses, infants, children and young adults with congenital heart disease. We care with those with acquired heart disease in infancy and childhood, and we also perform the screening, assessment and treatment of patients at risk of cardiac complications due to other disease processes. And so our role is really split up into various different domains. A lot of my work is done in clinically assessing patients. So I work out of an office in the hospital and we perform bedside tests, including ECGs and exercise testing, in addition to your typical history, examination, and such findings. We are imaging specialists and we're multimodality imaging specialists. We will be talking more about ultrasound in particular, but we also work closely with radiographers and radiologists in terms of plain film and cross-sectional imaging, as well as magnetic resonance imaging. We are interventionists, and although cardiology does have a super subspecialism of interventional cardiology, where we have my colleagues doing large stents in little people, we also do some procedures more generally. And on the screen is an example of one I do still perform myself, which is a balloon atrial septostomy, where ironically for a specialty that looks after children with holes in the heart, we actually sometimes need to make an extra one. And we just have here an ultrasound view of the heart, and we've got this kind of balloon crossing through into the back of the left atrium. And you'll see in a moment, we just pull that through to create a larger hole. And a lot of my work in the hospital is also around the peri and post-surgical care. We work very closely with intensive care physicians, cardiothoracic surgeons, as well as our nursing and allied health specialists to provide care around the time of surgery so that we can provide repairs and surgical palliations for our patients. And so one of the things I wanted to talk today is just about some of the paediatric cardiology pearls that I think are really useful for someone to know when you're presenting, when a child's presenting to you, be that in a community environment or an acute response environment. And importantly, why and what should you do if you think it might be congenital heart disease? And it's useful because congenital heart disease does affect 1 in 100 people. So about 1 in 100 people that you will interact with will have congenital heart disease. And 10 to 25% of these will have severe or critical lesions. So these are the ones that will almost always need surgery in childhood. And that's still 1 to 2 per 1,000 patients. Thankfully, antenatal diagnosis is the most common in the modern era in developed countries. And for some lesions, we can diagnose up to 90% of them before birth. And it's at least 50% for most of our lesions. But a normal scan before birth does not exclude congenital heart disease. And we do have patients who have got less access to antenatal care and therefore may be at higher risk of missed or undiagnosed congenital heart disease. So if you think it might be congenital heart disease, what you need to think about is, are they shocked? Are they cyanosed? Or are they failing? Do they have signs of heart failure? And what sort of things could they have? Well, they could have congenital heart disease. So the atrial and ventricular septal defects, people will have heard of tetralogy of Fallot, and more rare things, but important, like the transposition of the greater artery, or the hyperplastic heart syndrome, such as hyperplastic left heart syndrome. Children and adults may also present with repaired and known lesions, and in particular may develop early or even late complications of these, because congenital heart disease, even with surgical treatment, is a lifelong diagnosis. And more rarely, you'll find patients at an older age who will have an unrepaired or a new diagnosis or an unknown diagnosis of congenital heart disease. Importantly, children do get acquired heart disease, and although not the majority of our work, infectious and inflammatory causes are quite important, but also metabolic, patients involved in trauma situations, and as complications of systemic disease. And certainly, we are still in the middle of a pandemic, and SARS-CoV-2, the virus that causes COVID-19, as well as the mRNA vaccines used to prevent the serious sequelae, are both associated with myocarditis and other cardiac complications. And of course, arrhythmias can present at any age, including through early childhood. And they can present often for the first time in the community, either through a general practice or community setting, or by calling an ambulance. And so the first pearl I want to give you is that the presentation of all of these changes significantly with age. And I want to give you a little bit of a framework of how to think about that. And we think about a timeline of presenting 6 weeks before birth, and often that's the wrong ED or the wrong service if they're coming to me. They may present 6 hours after birth, 6 days, 6 weeks, 6 months, or 6 years. And of course, these are broad categories to help us think about them. And those type of presentations, again, are cardiac causes of shock or collapse, cardiac causes of cyanosis or blueness, and cardiac causes of pulmonary edema and high pulmonary blood flow, which are the main symptoms of heart failure in childhood. Now, I will occasionally mention the no palpable pulses, and I just want to be very clear here. I'm talking about that as literally not being able to feel pulses, but actually in a child with cardiac output, so clear signs of life. And I'm usually referring to not feeling a femoral pulse on examination, but this may include brachial pulses or unable to get a blood pressure on your machine in a child who's clearly alert and interactive. So we're not talking here about a child who clearly meets criteria for immediate advanced life support techniques. So thinking about before birth, I did say many of our patients are diagnosed before birth nowadays. They may present with a variety of things, including arrhythmias, complete heart block in children of lupus. We might see critically obstructed lesions, so the double outlet obstruction and obstructed truncus, severe valve regurgitations, issues with myocardial function, and also rarely we find congenital coronary artery disease. And they may present before birth or after birth in addition to findings. But one of the common times you'll find this is when there's an antenatal diagnosis where a mother has gone into premature labour. Because what we often do with the more severe diagnoses, particularly in areas that have got large geographic footprints, such as Queensland, we'll organise for them to come to the tertiary centre or near the tertiary centre for delivery about 4 to 6 weeks before the estimated due date. And the reason for that is outcomes for complex congenital heart disease are associated with the distance from the treating centre at birth. And in the most extreme circumstances, we will actually be setting up for immediate post-birth intervention. And this, for instance, is an extracorporeal membrane oxygenation circuit. And so some of our patients will need extracorporeal life support within the first minutes after birth so that we can get some essential interventions done immediately and stabilise them so that we can get a later surgical. And so if you've got a woman presenting with labour with an antenatal diagnosis of congenital heart disease, getting in contact early with the maternal fetal medicine unit is essential. We want the child to be born near to us, but we don't want them to be born on the way. So having those obstetricians and that multidisciplinary team on board is really important. After the child is born, if we don't know what to expect, what we need to be thinking is the baby shocked? So the pulseless and pale baby, think about those critical stenosis, interrupted arch, and occasionally a coarctation of aorta. The cyanosed babies, think about pale blue babies. The very complex congenital heart disease can present at this, but a blue but not all that unwell seeming baby, we're often talking about shunting lesions and mixing lesions. So the transposition of the great arteries will often present with a fully conscious baby with saturations that are unrecordable. Pulmonary atresia and critical pulmonary stenosis will have a duct-dependent pulmonary circulation. And then very occasionally we'll have a child who's failing early after birth. And so this might be a case of missed high drops, but occasionally things like the obstructed total anomalous pulmonary venous drainage will present with pulmonary edema soon after birth, after we first start to try and use the lungs. If we're shocked, they may otherwise examine normally, but often they'll have present pale and be poorly perfused. And so if there are no pulses, beware the heart. And again, we're talking about signs of life, but not being able to feel those peripheral pulses. If they are cyanosed, we're thinking about those duct-dependent and centrally mixing lesions. So beware the cyanotic infant without respiratory distress. Now, they are often not breathless, but it's because of less flow to the lungs, not more. And it's actually really easy to clear carbon dioxide. So they often won't actually present necessarily suprotachypnea or working particularly hard. Once we get through that, again, 6 days onwards, we're starting to think more about the obstructive lesions. So coarctation becomes more important from this point. We may start to be more obvious in our cyanosis. And so because the cardiovascular system is largely adapted to the postnatal life by this stage, the congenital shunts, the arterial duct and the atrial septal defect are closing or closed, and the pulmonary vascular resistance is falling, which means the ability for extra blood to be sent to the lungs is increasing. If the child is unable to tolerate this, it is usually due to those critical or obstructive lesions. So in that context, at 6 weeks after birth, beware the breathless baby with a noisy heart, because these are often shunting or obstructive lesions that are causing both a murmur and issues. Again, that PVR continues to fall, and what we're now showing is signs of maladaptation 6 weeks after birth. If they are shocked, they will have those obstructive lesions, but actually we're more likely to be having failing hearts here. So shunting, and unless they're driven by also having obstruction, usually the shunts that cause significant respiratory distress will have abnormal clinical findings, will be causing those murmurs. As we get past the 6-week mark, after all of our coarctations have closed, if they're going to, after our children have managed to survive that early fall in pulmonary vascular disease, we start thinking about the 6-month mark. And this means that the baby has managed to tolerate that drop PVR, but the adaptive changes have started to become overwhelmed. So occasionally we see previously balanced lesions where we have had adequate mixing and adequate blood flow to the lungs, but they are becoming less suitable as the child grows. But most of what we're seeing here are the ventricular septal defects and the atrioventricular septal defects, or valve lesions, where there is extra workload on the heart. And the kid has coped with that when they've been 3 or 4 kilos, but now they're trying to get to 7 or 8 kilos. All of that energy is taking its toll. And so although they may present shocked, that is rarely congenital at this point. So think about the acquired cardiomyopathies and myocarditis. If they are cyanosed, we're usually thinking about the stenosis of a previously balanced anatomy. So these are the tetralogy of fellows who might be starting to become blue or demonstrating their first hypercyanotic episodes. But importantly, the failing patients will be presenting here. And usually these are noisy shunts, shunts after pressure, and also after the AV valves. And it's hard to be failing with normal growth centiles. So definitely beware the scrawny infant who presents with a murmur and generally unwell in the couple of months of age. Finally, the last important group to think about is those actual childhood ages, so the 6 years after birth. So these children have demonstrated that they've tolerated the dropping in PVR, they've potentially had prolonged high cardiac workloads. So to get there without having other signs and symptoms of congenital disease is relatively unusual, with a few exceptions. Therefore, we need to be thinking about those acquired lesions, rheumatic heart disease, cardiomyopathy or myocarditis, Kawasaki's disease, and uncommon but important inflammatory disease that affects the coronary arteries in addition to skin and other organs. And in the current context, the COVID-19 related myocarditis, plus or minus the PIMS-TS, the multi-system inflammatory disorder that goes with temporally related to COVID-19. If they are shocked, again, rarely going to be congenital at this point, but do think about acquired heart disease. If they are cyanosis, usually they've previously tolerated this, but we may have progressive pulmonary stenosis. Very rarely, but very nastily, these might be the earliest presenters with an Eisenmenger physiology, where the patient has had a previous shunting lesion, but have damaged their pulmonary vasculature to the point where the shunt has started to reverse. And lastly, the failing patients, the main cause here is going to be an atrial septal defect. And usually this heart failure is mild, but the acquired valve lesions and acquired causes of complications of previous lesions are important. So as we think about going through those different ages, I hope that gives you a little bit of a framework about how we think about the shocked, cyanosed and failing child. Pearl number 2 is I'm much less worried about cyanosis than you are. And I just want to go through a brief thought exercise. How long does it take to lose consciousness if you hold your breath? And I want you to contrast that with how long it takes to lose consciousness if I drastically reduce your heart rate. And the answer, not surprisingly, is the world record for a voluntary breath hold is 24 minutes and 30 seconds. But if you have vasovagal syncope, you will lose consciousness within 6 to 10 seconds of a sinus pause. So cardiac output is very important when it comes to loss of consciousness, but actually cyanosis can be very well accommodated. And of course, this is an unfair comparison because chronic hypoxia in particular has many adaptive mechanisms. What we're usually actually worried about is oxygen delivery and the dissolved tissue oxygen pressure, because that's what the cells actually need to perform aerobic respiration. If I send more blood at lower saturations, I'm still going to deliver that oxygen, so I can increase my cardiac output. I can increase the oxygen transport at a given saturation by increasing my hemoglobin, and I can have hemoglobin that's particularly efficient at dissociating at lower saturations, such as the fetal hemoglobin present soon after birth, and also in certain other lesions, such as the thalassemias or sickle cell disease, particularly if they are on treatment. And fetal oxygen saturations before birth are often in the 40 to 60% range for that 9 months of pregnancy. Cyanosis in congenital heart disease, therefore, is not usually because of poor oxygen extraction, but because of cyanotic blood being sent to the body. And we call this mixing. And this is quite an important thing to think about. In people with normally organised hearts and vasculature, when we see cyanosis, usually we have a failure of oxygen extraction, whereas actually what we're looking at in cyanotic congenital heart disease is the ratio of blood flow being sent to the lungs or to the body and then getting mixed. Now, this does not mean that cyanosis is unimportant, because acute changes are poorly tolerated. Non-cardiac cyanosis, where there is not mixing, will often go with poor extraction, and hypercarbia will present as respiratory failure. And peripheral saturations are poor where there is higher oxygen consumption, sepsis, shock, as well as malperfusion, etc. And remembering the pulse oximeter is an estimation based on a whole bunch of variables that really means most of our pulse oximeters aren't actually point accurate below about 94%. Trends are important though. So when you have a child who's cyanosis, ask the parent, what are the usual saturations? Many of our patients with complex hearts will be stable and cyanosed in the community. Targets will usually be expressed in fairly broad terms, so greater than 90%, 80 to 90%, or greater than 70%, depending on the lesion. And in general, a deviation of 5 to 10% below the expected value is possibly significant. And the higher the baseline saturations, the smaller a change tends to be significant. And part of that has to do with the accuracy of pulse oximetry. A deviation of greater than 10% is almost always significant, and arbitrarily consider anything less than 70% as quite unusual unless the patient is toward end stage. May not mean they're necessarily unstable, but it usually means that my service needs to sort something out fairly quickly. And if we can't ask the patient if there are concerns that this is a more chronic thing, look for other service sources. There may be an ambulance service letter if they've got that tied to the right location. The viewer or equivalent statewide medical record access is important. Of course, My Health Record ideally has a copy of most of the specialist letters, although in practicality that's not necessarily the case. But absolutely, you can call the doctors. So most of our cardiology trainees, paediatric cardiology trainees, will be able to hear something about the history and give you some guidance towards what these saturations should be. Now, all that said, and if you read in the textbooks, you might have been heard that some children with congenital heart disease will deteriorate if they're given oxygen. And I want to be very clear, I don't want you to hesitate to give oxygen in an acute situation where you don't know that it's bad. I am far more comfortable at low saturations, but that is because I know why they have low oxygen saturations. And there are some situations where oxygen can be detrimental, but those patients are actually rarely in the community. Certainly infants with shunt-dependent systemic circulation, where there's more blood flow by giving oxygen, this is sort of a robbing Peter to pay Paul situation, so we can end up with lower systemic perfusion. But nonetheless, this is mostly an issue when oxygen is given at near normal saturations and when no longer required. But failure to respond to oxygen is a very important clue that we've got that mixing criteria. And if it's not because of cardiac mixing, then it probably means they've got severe oxygen extraction, i.e. a lung issue, so they probably need the oxygenose. Now, non-cardiac causes of cyanosis predominate in our community. Even in the neonatal period, the most common causes are neonatal sepsis and failure of transition to postnatal life, which comes along with that. So just because they're cyanosed doesn't mean they're congenital heart disease. And that's why I don't want you to hesitate to give oxygen if you're worried. Now, my third pearl today is chest pain is chest pain. not heart pain, particularly in children. And chest pain is a common presenting feature in children and adolescents, actually accounting for a large number of attendances to hospital for children and adolescents. It's important to know that ischemic heart disease is not common in children. And when we look at the causes where we can identify a clear cause, certainly idiopathic and musculoskeletal are very important. Injury post-exercise is quite common. Costochondritis, irritation of the chest wall, is quite common. And ischemic chest pain is rarely worse when you touch the chest. And the precordial catch syndrome is worth particular mention. These are the short, sharp pains that usually adolescents feel. And it's not necessarily pleuritic, but it often feels the feeling of catching of breath. And these will be of random onset and often quite severe and will interrupt what they're doing at the time, but generally fade without treatment. And the course is very benign. Respiratory illnesses are important. Asthma, obviously, we have high rates in Australia, pneumonia and post-viral pleuritic pain, which can occasionally go with pericarditis and be a bit difficult to determine clinically which one is the other. Certainly, I, as a paediatric cardiologist, occasionally diagnose gastritis and reflux, and I have had a child referred to me for chest pain who actually had a Mallory-Weiss, and yes, I am a paediatric doctor. Now, cardiac causes of chest pain are still very uncommon, but probably the main one that I do want to know about is arrhythmia. So the tachyarrhythmias do have higher cardiac workload, potentially a poorer cardiac perfusion because of less diastolic filling time. So do an ECG, because if I can work out what the rhythm is, that can help me treat it accurately. Clearly, myocarditis and pericarditis can present with chest pain. So again, that ECG earlier and when we've got the pain is important. There are, of course, rare coronary artery abnormalities. So beware the child with a stenotomy. They are one of the few children where there is actually a likelihood of coronary artery disease, but it's mostly post-surgical. And actually, most of our surgeries do not touch the coronary arteries at all. Rare causes, however, where you do have ischemia, will show typical ischemic changes. So again, do that ECG. And just as an example, this is an ECG in a patient with an anomalous left coronary artery, and acknowledging that it's a pediatric ECG, so it's clearly much faster than we would see in an adult. We have widespread ST elevation. We have pathological Q waves laterally. We've got a very bizarre axis. And so hopefully if you're seeing ST segments that look like this in any patient, you are worried about the heart. And if you get that to me, we're going to be worried about it too. Sorry, that's just arrows for that as well. Now, do and retain those ECG during the symptoms, but also afterwards. If the ECG is getting better, if the chest pain is getting better, we need to see whether there is dynamic ECG changes, because this is the test that helps us exclude an arrhythmia. This is the test that helps us exclude dynamic ECG changes for the very unlikely causes of congenital coronary artery abnormalities. I also want to acknowledge hospitals are horrible at retaining your ECG, so please, please, please keep an electronic copy and a photocopy, preferably a high resolution setting in colour, prior to giving it to the nurse or doctor if you can. Of course, that depends on your local rules and privacy legislation, so please review that with your supervisors. So those are my three main cardiac pearls. And so these are the things that I want everyone really to know and think about when they think about children having congenital heart disease. Just briefly, I do want to acknowledge the sources for some of these images, which have been shared either under fair use or a variety of Creative Commons licenses. Now, just moving on to the second part of the talk today, I'd like to introduce you to Point of Care Cardiac Ultrasound, or POCUS. And Point of Care Cardiac Ultrasound is an ultrasound which means we're using sound to make images. Focused, so limited targets, limited lesion identification, and it's rapid. It's often done alongside a fast scan in a trauma or resuscitation scenario. And it's performed at the point of care. So we're trying to be mobile, flexible, and adaptive. And with the progression over the last 20 years to the point where we have reasonable quality handheld echocardiogram, or at least ultrasound devices, it's becoming more and more available in more and more peripheral services. Training and accreditation in point-of-care ultrasound has developed distinctly through the acute care services and is separate from what we do with echocardiography, but there is clearly lots of overlap. And there is increasing evidence-based use in the emergency department, intensive care, and both peripheral and primary care. It's important to note that learning acquisition of cardiac POCUS is much, much easier than learning the interpretation. So you can do and just highlighting that this is still studied. We have known for a while that it does improve our ability to recognize things like cardiomegaly, left ventricular dysfunction, and pericardial effusions. And it does, even in the hands of non-doctors, improve sensitivity for screening of important diseases like rheumatic heart disease when done in an appropriate framework and with backup. Your initial training in point-of-care ultrasound should generally be through a registered provider. There is a paucity of formal accreditation, but several providers are available. They are often focused on medical practitioners, though. I do like the College of Intensive Care Medicine, which in 2014 decided that all of their trainees would need to be able to perform a point-of-care cardiac ultrasound, and they've got quite a nice list there, which I have no part in. A couple of examples of what you might need to Google or look for is courses that mention basic echocardiography in life support, rapid cardiac echocardiography, and the 1- and 2-day focused cardiac ultrasound courses. And these will usually be enough to familiarize yourself with the technology, with the basic 4 views that we look at in point-of-care ultrasound, and some of the main lesions that we're going to be looking at. But they're not enough in the own to be going out there and doing practice, particularly not as a registered provider. And so for advanced training, again, it's important to note there are a paucity of accredited echocardiographers in Australasia. So if you're thinking about, oh, I'd really like that, actually this is a potential career path for you to go through. With formal postgraduate training, what you need to be looking for are either graduate certificate in cardiac ultrasound if you've got an appropriate prior bachelor, and in Australia the graduate diploma, which may be offered in addition to a Bachelor of Echocardiography and Cardiac Physiology. Usually a science-based science-based bachelor degree will be required, and many of you may find that you'll be able to cross-train in this quite with some convincing, but actually very practically. And beyond that, you will need a supervised position to then acquire these clinical skills in practice. And this is starting to move more into that formal echocardiographer role. So how do we actually do it? Well, the point-of-care ultrasound consists of 4 views of the heart. We start with a subxiphoid, we do the parasternal long axis, the parasternal short axis, and then the apical forechamber. There are a variety of modifications of these views that we can use to look at other things, but that is not the focus of point-of-care cardiac ultrasound. I will make a disclaimer, I am a paediatrician. So in pediatrics, we show the heart the right way up. But in adults, we show the picture the way the probe intended. So I do things the right way, and you'll have to forgive me. You'll see a lot of online and traditional resources focused on adult point-of-care ultrasound who will flip particularly the apical forechamber and the subxiphoid views. I can look at both, but I've kept the pictures the right way up in terms of trying to present them properly. So the subxiphoid, also known as the subcostal view, is a view from inferior to the xiphisternum, and it's looking up at the heart. It's great for looking at pericardial effusions and a general assessment of function. And in association with that fast ultrasound or resuscitation requirements, by rotating the probe 90 degrees, you can look at the inferior vena cava, which is an important assessment of right atrial pressure and the likelihood response to filling in an acute resuscitation environment. This is a view of one of my patients. So that in this view, looking up from the subxiphoid, we have the liver is often centrally and off to the patient's right, the left of this view. We're seeing the atria at the back, and we're seeing the ventricular mass out the front. And again, we're getting a general view of how well that myocardium, that cardiac muscle, is functioning. We move to the parasternal long axis, and this is a workhorse view. It helps us look down at the heart along with the long axis of the heart. And although we're looking for effusions and aortic issues, this is really an important view for looking at left ventricular function. From this view, we will be able to rotate 90 degrees to move to the parasternal short axis view. But this view, where we have the apex of the heart towards one side of the screen, the base of the heart with the aorta in the middle and the left atria behind, is an important view. In particular, we see a little bit of the right ventricle. And although not great at assessing this, we have excellent views of the left ventricle. We can assess how well it is filled. We can assess how well it is ejecting or squeezing. And so this is actually the view that an adult echocardiography will often go to start with, because from this view, you've got a one look at, oh yeah, the heart squeeze. Parasternal short axis, as I said, is 90 degrees from the long axis. So this is in the short axis of the heart, which is cross-sectional to that parasternal long axis. It is acquired just left of the sternum. And again, we're looking for effusions and ventricular function. And what we see here is we see the right ventricle out and crescent shaped in front. And we see the circular body of the left ventricle. In this case, we just see the mitral valve at the back. And so we're looking to see, are there any regional differences in that myocardial function of the left ventricle? And we actually get a better view of the right ventricle here. In adults, you won't often see quite as much of the right ventricle here. These are actually the rib here, so we're trying to sneak in between this rib space to try and get a good view. The apical four-chamber is the last view, and this is the one that I often show to my patients and say, look, this is what a heart looks like. And it's a view from the apex of the heart, usually just below the left nipple. If you feel for the point of maximum cardiac impulse and put the probe on it, this is usually where you'll find the apical four view. You're looking up at the heart, and it's aligned to try and see all four chambers. You're looking for size differences in those chambers, some assessment of biventricular function, and of course, looking for those effusions. This view is the one where you'll often see evidence of significant right heart problems and function and distension, and that's often used in the assessment of pulmonary embolism in the previously well but now breathless and potentially chest pain patient. And so in the apical four-chamber view, again, acknowledging as a pediatric doctor, I look up at the heart. We have the atria at the back of the heart. We have the two ventricles with the left ventricle to this side of the screen as if I'm looking down into the patient, and the right ventricle here. And what we want to see is that all of the left ventricle is moving, that the right ventricle is moving, and that it's slightly smaller in terms of this lateral dimension than the left ventricle. Now, if we see a poorly functioning distended right ventricle, then we have to worry about right-sided problems. And the main one that we're interested in worrying about is that pulmonary embolism. Very occasionally, you will see a thrombus in transit. And I'm sorry, I can't share any of those pictures with you today. Now, in terms of what sort of things are we going to see, I'm going to show you a couple of markedly abnormal ones. This is a subxiphoid view of a child who has one of those rare congenital artery abnormalities called Al-Kappa, or anomalous left coronary artery from the pulmonary artery. And this is a lesion where the left main coronary artery arises from the pulmonary artery. And early after birth, those pulmonary vessels are relatively stiff and the pressure remains high enough to perfuse the myocardium. But in the months after birth, as it becomes easier and easier for the blood to move through the lungs, the pressure drops and the left main territory becomes progressively ischemic. And so we have a dilated heart with a regional wall motion abnormality. We actually have a small amount of effusion here, but this is probably not clinically significant. Moving to the apical long view, we see something quite different from that previous view. We see that this muscle here is working But if I can convince you here, this is just rocking backwards and forwards. We actually also have a distended left atrium, and there's a big size mismatch here where the left ventricle is quite large. More subtle features that you wouldn't be expected to pick up on necessarily with point of care ultrasound is we actually see a very bright papillary muscle, the anchoring point of that mitral valve, and this often means that that muscle is acutely ischemic, acutely or subacutely. And this is the short axis view. And again, this is a cross-sectional view. We're seeing the left ventricle here in cross-section, and it's nice and circular. And again, similar to that last view, the septum, the middle muscle of that left ventricle, is still doing something. But as we look more laterally and inferiorly, we see that this is a thin muscle that doesn't squeeze particularly well. In fact, it squeezes very, very poorly. And then again, from the apical four-chamber view, again, we see this massively dilated heart. You'll have to take my word that it's dilated, but we also see that although we've got some function of this muscle where it shortens, actually out the side here, we've got thin muscle that doesn't thicken through the cardiac cycle. And absolutely, you could be saying, is this a dilated cardiomyopathy? But the most important thing here is saying this is a heart that is dilated, squeezing poorly. There is probably a heart problem here. Pericardial effusions, with tamponade being the extreme clinical presentation where it's affecting the hemodynamics, is important. And this is a massive pericardial effusion. Usually the pericardial space has just a few mils of of fluid in it, which acts as a lubricant and cushion. This child's heart from the subxiphoid view sits here, and it's sitting in a bucket of basically water. And as we look through some of the other views in the long axis, it's very hard to get good views here, but we see a large amount of fluid around the heart. As we move on to the short axis, again, the heart is sitting here. There are some other things going on with this heart that I won't necessarily talk through, but we are seeing some right heart dysfunction as well. And we see a size discrepancy here, which, as I mentioned, makes you need to think about those pulmonary emboli. But here is the heart, here is the pericardium. Hearts shouldn't be sitting in buckets of water. And then again, from the apical four, now this doesn't look a lot different to the subxiphoid because of the amount of fluid here, but we see fluid all around the heart. But we still see myocardial function. This child actually does have tamponade, and one of the things that we start looking for is changes in the atrium and the right ventricle size here. And this is actually fluid flopping in and out around the right atria, and some difference with breathing changes those pressures enough for us to find it on the outside with that pulsus paradoxus. Now, lastly, just a few pictures of one of my patients. This is cardiac hypertrophy, and this is from that long axis where previously we had nice thin myocardium on both sides. Here we've got a big bulk of muscle in the middle. And in particularly in the more adult patients, that hypertrophic cardiomyopathy can be from a vast variety of things, but is often associated with dysfunction. Now, this child's heart actually squeezes relatively well, but we've got that big bulky septum, and that actually gets in the way and can cause murmurs and obstruction and make you quite unwell. So some concluding thoughts in terms of the cardiac point of care ultrasound. It is becoming more widespread, more accessible, and more shareable. In the digital healthcare environment, in an ideal situation, you should be able to be at the point of care of a patient and be able for those images to be immediately and in real time viewed by a subspecialist in the receiving centre or in a referral centre to give you advice about those diagnoses. So I do think that just the acquisition will in the future be an important skill for people to have when we're out in the community. And it does represent an opportunity for community, hospitalists and acute care responders in the future. As we are learning more about how to use this tool to guide resuscitation so that we're getting the right fluid volumes, knowing that too much fluid is not good, but not enough fluid is definitely not good. Thinking about, well, is this cardiac dysfunction, and it doesn't tell you why the heart is dysfunctional, but it does tell you that it is dysfunctional. And if it's full enough with fluid, that's where you might be guided towards those more inotropic type therapies. And if you've got a normally functioning, normally filling heart and you still don't have a blood pressure, that's where you start thinking about the septic shock, where you might actually need some vasopressor. And I don't want to go too much into the detail. This is an ongoing area where we are learning more and more how to use these skills, but the acquisition of those pictures is something that you can use to inform the receiving teams and inform your referring teams what needs to be done, and to help you optimize that resuscitation and assessment for a couple of very important life-threatening situations. So thank you very much for joining me today. That's it for my presentation.
Thank you so much, Dr. Lauren. That was absolutely fantastic. And I'll remind everyone, if you have any questions who are live here today, please go and pop them into the comments section and we can directly ask Dr. Lauren right now. But thank you so much for presenting that. That was really fantastic. I might just start off with a question, if that's okay for you. And I wanted to know, I was interested in, are there any common demographics that you noticed in your experience with regards to patients with congenital cardiac illnesses? What areas of society or where do people live that you commonly see? Are there any trends in that?
Absolutely. So I suppose there's 2 points to say in that. The first is that complex congenital heart disease does have a higher burden in patients with low socioeconomic status and poorer access to healthcare. And in particular, that antenatal diagnosis gap becomes more important the more peripheral you are, the further you are from that tertiary centre. And because that affects your outcome, these patients are at higher risk. We work in diverse situations, and certainly what we deal with in Queensland is a very geographically spread out concentration of patients, where we have patients who are potentially thousands of kilometres away from us that we're trying to support and manage. But most of our patients will spend most of their lives in the community. And that's the second important thing to know, is that most patients who have congenital heart disease are now adults. So congenital heart disease is something that we will need to be familiar with. And as more of those adults start surviving into their 50s and 60s and having very late complications and overlap between their congenital heart disease and the lifestyle-based or genetically based acquired heart disease, that will become more and more important with time. But certainly our First Nation peoples and our low socioeconomic peoples bear a burden of both acquired and congenital heart disease. Particularly, there is no excuse, I think, for our nations to have the rheumatic heart disease rates that we have. It means a failure to deliver healthcare to our most vulnerable and First Nations peoples.
Thank you. Joel has added a question here, and he wanted to just ask, how do you approach analysing the paediatric ECG? This is quite a large question, I'd imagine.
Yeah,
Go ahead.
No, an excellent question. And I suppose what I might refer to is, at the end of the day, the heart's got to do a couple of things. It's got to start a heartbeat. It's got to get that heartbeat from the atria down to the ventricles, and it's got to do it in a physiologically appropriate manner. So the main difference between pediatrics and adults is mostly one of timing and access. The heart is smaller, the heart is oriented slightly differently in the chest, and this is what accounts for most of the changes. Now, there are specific changes that the infant goes through, and that has to do with the adaptation to post-fetal life, where the right ventricle starts relatively dominant and becomes less so over time as the left ventricle becomes more dominant with that higher afterload and the blood pressure increase. Now, there are some tools that help you interpret that. So without being associated at all, there's an app called, let me just get it. So I've got it, Rapid Pediatric ECG Interpretation, that will be available on your phones, which will help you go through those intervals if you're worried. But ultimately, the main thing is there's a couple of very simple things to know. Incomplete right bundle branch blocks, particularly anything less than 90 milliseconds, probably fine. Fast rates, almost certainly fine. And in fact, a physiological heart rate for a child is anywhere up to 220 beats per minute if they need to. And the situation you will often be focusing on those sort of things is sepsis. But if you don't see that P wave, if you're not sure of that rhythm, absolutely repeat the ECG and get it to a specialist. Your pediatric and general ED physicians should be well and truly competent at interpreting these ECGs. And the harsh reality is you can always get it to one of us via them, and we answer ECG questions 24 hours a day for not necessarily as much always required, but certainly those more tricky questions are important. Broad QRSs are almost always abnormal. So if they don't have a scar on their chest and you see a big left bundle branch block or a QRS duration in excess of 110 milliseconds, which is really, quite wide for most normal children, you need to be worried. And anything that you're just not sure of, absolutely give us a call and buzz. Probably the other big one to be aware of is that benign early repolarization, much more common in children and adolescents. But at the end of the day, benign early repolarization does not cause chest pain, whereas acute ST changes that are dynamic might be from chest pain, although in pediatrics, it's more likely to be pericarditis.
Thank you. Another question from Daniel here. You mentioned the preference for women to be at your facility prior to the birth where there is known issues. Have you been involved with retrieval of unwell newborns, and how have they been challenging from a logistical perspective? In particular, you mentioned ECMO. That's obviously not available in all areas around the state and the country, but have you got any experience in that?
Absolutely. So we're often heavily involved in the assessment of particularly critically unwell infants who don't have an antenatal diagnosis. So we often are going through our checklist. Is this child cyanosed? Is this child relying on that patent arterial duct for either perfusion of the lungs or perfusion of the body? Or is this a cardiac dysfunction issue? And when we're working through that, we've got a couple of incredibly powerful and useful tools, the most important of which I'd say is the prostaglandin infusions, which can maintain a patent arterial duct and bias that time for retrieval at the cost of potentially sending lots of extra blood flow down to the lungs. So when you're retrieving or working with a retrieval team for some of these critically unwell infants, if people are worried about congenital heart disease, you'll often find that they're on this prostaglandin. Our Prostadil is the brand or the drug name that we tend to use in Australia. Importantly, this is a New Zealand technique, I should mention, as I think was the balloon septostomy from memory. So we use that to buy that time to assessment. But at the end of the day, the child will still need resuscitation. So those basics of, airway, breathing, circulation, adequate fill to be able to do whatever's going on, and oxygenation to try and support those SATs somewhere up above 90 if possible, but if not, reasonable amount of respiratory support. In terms of retrieving in utero, we are certainly involved. So on my last on-call week, we retrieved a woman from Rockhampton who went into spontaneous premature labour. Her flight was booked the following day. So unfortunately, she had a slightly earlier flight, and we retrieved her to a tertiary centre, and we actually had our surgeons in the room with that ECMO to be able to put onto ECMO in case we needed to. Actually, we were able to get adequate access and do that balloon septostomy prompt enough that we haven't needed to do that, but we've certainly had a couple of cases where we've gone on to veno-venous ECMO to be able to support oxygenation. Now, ECMO in children, it's very important historically. I want to acknowledge that paediatricians, neonatologists and paediatric cardiothoracic surgeons kept ECMO alive from the 80s through to the 2009 H1N1 influenza outbreak, because between that time it had basically been abandoned for adult medicine, but we've been plugging at it and kept it alive. And ECMO is absolutely something that we will be seeing emerging onto the front lines in acute resuscitation, but it will mostly be in adults because children and babies usually need central access, which means a sternotomy. There is a critical size threshold for those more portable systems to be used on, because that's what you need to be able to do femoral or cervical access for that, and you need a physical size thing for that. So that's not quite there, but certainly we're seeing more and more patients going particularly on veno-venous ECMO in the emergency department, and in some situations actually in the field with specific teams. The portable ECMO is not really a thing. We're talking about something, a setup that's roughly the size of a small washing machine.
Yeah. Sue's got a question. Is there a role for caffeine with neonates with congenital heart defects and poor perfusion?
Probably not. So the caffeine is mostly used in these situations where we've got apnea. So one of the side effects of those prostaglandin infusions, for reasons we don't necessarily understand because it's a child problem, not an adult problem, so there's much less research into this sort of stuff. But we do have, inhibition of those prostacyclins, and we do have patients that will just decide to stop breathing. And maybe that has to do with the way we're manipulating the signaling to trick the heart and vascular system into thinking it needs to have a fetal circulation. So those patients will often be placed on caffeine if they've got apneas, but it's probably more to support non-invasive ventilation, because your backup for that is to proceed with intubation and ventilation. And depending on what's going on, that can sometimes make things worse. If we're relying on certain mechanical properties and respiratory cardiac interactions, mechanical ventilation is not always the answer, but when you've got a sick kid, it often is. So I wouldn't say I use caffeine specifically with the poor perfusion, although I'd be very willing to look into that in the future.
I wanted to follow up with what you were speaking about just at the start of the questions here with regards to demographics and the high rates of Indigenous cardiac illness and rheumatic heart disease. I'm interested in a remote clinician, a primary healthcare clinician. If we can imagine for a moment a paramedic practitioner or a general practitioner working in a remote area of the country who is confronted by a patient, or a patient may have come in, a young child, and there was suspicion of congenital cardiac illness at that stage. They're a long way away from a major healthcare facility. I presume that being able to have training in POCUS and have that equipment on site would be a very valuable tool to be able to determine the urgency of retrieval, if required, of that patient and consult. Would you speak to that, and would you advise rural clinicians to really look into POCUS and the benefits of that?
Oh, absolutely. The Australian College of Rural and Remote Medicine does recognise the role of POCUS and actually accredits a number of courses towards that end. I would clarify, though, it's not necessarily diagnosing the congenital lesion. What you're doing is you're excluding some of particularly the acquired issues, that cardiac dysfunction, that pericardial effusion, and the poor filling, because these are some acute life-threatening things that may need to be intervened on before retrieval, and you can inform the right team and the right destination early on. If you've got that backup of someone else to be able to look at those pictures, they may be able to put more in that. If you see a big hole in the septum, there's probably a ventricular septal defect, but that's probably not where the focus of this role is going to be useful in. It's going to be in making sure that you don't have that severe pulmonary hypertension from the pulmonary embolism, that severe cardiac dysfunction that needs retrieval and advanced life support techniques, that pericardial effusion that may need drainage. And you tie that into your FAST scan and similar. So are there effusions elsewhere? Are there trauma-related complications? Are you mobilising those teams before they end up at your tertiary or final treatment centre, so that they can give you the right advice early? They can guide your resuscitation and stabilisation early. And certainly none of the interventions are risk-free, of course, but you can save a life by tapping a tamponade. You can improve your resuscitation by giving extra filling when you've already met your criteria, but it's still not working, and it's just not ending up in the heart, it's ending up everywhere else.
Well, thank you very much, Dr. Lauren. That was just a fantastic presentation, really insightful. I've learned a lot, and it's inspired me to actually look into POCUS, and I'm certainly going to download that app. Can you repeat the name again? Pediatric
so rapid pediatric ECG interpretation. Again, no actual relationship myself. I'm just trying to see if I can.
But a good resource nonetheless.
Yeah, absolutely. So I use this in clinic. I'll just briefly flash it up if I can. No, it's opening too quickly.
Right. Rapid pediatric.
So these are the ones that I have on my phone for rapid access. So rheumatic heart disease, cardio Z scores is something you guys won't need. Drug doses, for better or worse, is wonderful, but rapid pediatric ECG gives you all of those numbers so that you can say, oh, there's a little bit of a Q wave in V6. Is this abnormal? Oh, actually, no, you're allowed a couple of millimeters of it. But, oh, no, this is 20 millimeters. That's a little bit different, those sort of things.
Well, thank you very much again for joining us today. And for everyone online live, thank you very much for all of your questions. I'll be uploading this through to YouTube, hopefully within the next 24 hours. So there'll be a post up on the ACPP forums to alert when that has occurred. I hope everyone has a good night and take care. Thank you.
Thank you very much for asking me to join you, and I look forward to seeing you next time.